Well, thank you all for coming out. This is the 107th time that LRH has had a annual community meeting, and so I always admire everybody coming out, particularly on a night like this where it hurts a little bit as you stand outside. For those of you I don't know, I'm Steve Truboff. I'm the chair of the Board of Trustees of LRH this year. I think you all know Warren West, our CEO and president. And our goal tonight is to share information both about what we're doing today, many of you are engaged and involved in that, and a little bit about the environment we're operating in and seeing ourselves operating in and where we think we're going. One of the interesting questions people ask me all the time is, who owns this place? I'm always shocked people ask that question. This is a community-owned hospital. You own this place. This is a classic 501c3 nonprofit, non-government, mission-driven organization in which whatever money we make is reinvested in the institution itself for the betterment of the community. And governance is by a board of trustees elected actually by the Board of Trustees for a term of up to 10 years. And we've changed that around a little bit, but roughly people are on 10-year terms, although we have some people that have served longer than that. Warren and I are going to talk a little bit about the environment we're working in. It's easy to sort of lose sight in the day-to-day of what we're doing to try to get some framework. You don't have to read a lot of newspapers or magazines to know that healthcare is a huge topic in America, and we're not, even though we're out in the country, we're very much a part of the challenges of that system. Give or take, depending on who's counting, healthcare represents 5% of the GDP. You all remember from your first course in economics, that's the gross domestic product, or all goods and services produced in the United States. What's interesting about that number, it's more than defense spending and non-defense. It's more than Social Security. It's more than all mandated programs together. I didn't put in, I've got tons of charts that show an arrow that looks like a ski slope going the other way that talks about how fast those costs are going up. For those of you who had the pleasure of reading the 28-page article by Steve Brill in Time magazine that talks about $10,000 bandages and all the abuses of the system, supposed abuses, the fact is the costs are very high and the costs are going up at a phenomenal rate. At the same time, while mortality rates, these arrows are not in proportion, mortality rates of hospital admissions have gone down a very small percentage. The cost of that have gone up thousands of percent. And so what's happening is we have this curve that's on the way up very quickly, and there's nothing that can stop it. And we as a society can't afford to pay for it. Something has got to give. And what all the conversation about it is what's going to give. There is some leveling out of that cost structure, but not fast enough. So everyone has their own explanation. One of the great things about this is if you ask people why healthcare costs too much, everybody's got a different story. You know, you can hear the story about insurance companies make a fortune off of our ills. Physicians are clearly overpaid. Hospitals gouge their patients. This whole thing about the charge master and how hospitals charge. Of course, if you looked at Bill's numbers carefully, we only collect about 50 to 60% of what we bill. Not covering people drives up costs. Covering people drives up costs. Medicare doesn't pay enough. Medicare pays too much. And of course, that I could do pages of that chart, including such things as the medical devices we buy in this country at wholesale that are made in Indiana, we can buy in Belgium at retail for half of what we pay at wholesale in this country. Or the fact that Medicare doesn't negotiate drug prices, or a whole lot of things like that. The fact of the matter is there are dozens of things that are driving up the cost of healthcare. And what everybody wants is a simple solution to a complex problem, and nothing like that exists. The truth is everybody's a little bit right and everybody's a little bit wrong. Some people aren't paid nearly enough for what they do, and some are probably paid too much. But the reality is it's a myriad of issues, and we're not going to have one simple solution that's going to fix the problem. We're also, by the way, our own worst enemies. This is a chart that I picked up from Dartmouth, but I happened to be at a debate about healthcare last week, and they had the same chart. The fact is 40% of all healthcare problems in this country are attributable to our own behavior. Smoking, sedentary lifestyle, and overweight are the killers, and they cause a whole series of diseases. And no matter who you listen to, is unless we can do something about changing those behavior patterns across a broad range of society, we are not going to lower health costs. By the way, 5% is attributable to physical environment, 15% to social circumstances, 10% to deficiencies in access, and the other 30% is roughly genetics or predisposition. But the fact of the matter is we need to manage population health, not let populations do what they want and try to pay for that health. It just simply isn't going to work. The interesting thing is most people that are in the business sort of get where it's going and understand the pattern, but the details are a little murky. For our planning purposes here, and we've been working probably for 3 to 4 years now trying to pull together a strategy of how we respond to going forward. The details, while murky, there are some patterns here. The first is nobody's going to pay us more for what we do than we're getting paid today. There are a few things that we might get paid more for, but in general, the payment for the services we provide is on a downward trend on a per-service basis. The fee-for-service charge, this is a piecework business, as you all know. You perform a service, you render a bill for that service, you take something off the shelf and whatever. That model of fee-for-service or piecework probably isn't going to disappear completely, but at some level there's going to be some form of population-based payment, first by Medicare, then by Medicaid, and ultimately by private insurers. And what that means, whether you call it capitation or population-based management or whatever, we're going to get $5,000 or $7,000 or $8,000 per life to manage 1,000 lives or 5,000 lives or 10,000 lives healthcare. And if we spend less than that, we're going to keep the difference. And if we spend more than that, we're going to end up paying the difference. How long it's going to take to get from here to there remains to be seen, but there are a series of national experiments like that that have been going on for half a dozen years, and it appears that it can be done and it can work, but it's going to have a huge impact on how we operate. Medicare is going to demand more every year and pay you less. That is the model. Those of us who are old enough and have the pleasure of being on Medicare understand the difference between what people bill and what actually gets paid. There is no percentage relationship. The numbers are too small. But the reality is Medicare is going to pay you less for everything you do, and they're going to demand more for that. The regulatory environment for rural America, that's us, is very uncertain. We are a critical access hospital, and that means that we get paid on certain costs rather than fee for service. Supposedly we're supposed to be 25 miles away from each other and meet a bunch of characteristics. The truth is there's a lot of hospitals that don't meet those characteristics, and we don't know whether that's going to continue. We don't know whether federally qualified healthcare centers like Ammonoosuc are going to get a check from the government like they've gotten for many different years. And so all that's sort of iffy. We know that the number of people practicing medicine isn't going up proportional to the population. Medical schools were supposed to grow. The truth is, if you're a university president, medical schools lose money. They're complicated. They have lots of people in them. They have equipment and facilities. If you're a university president, what you want is another business school. All you need is a couple books and computers, and you can charge almost as much. And so the truth of the matter is we are not generating enough physicians and healthcare providers to serve the population, and there's a huge shortage, both in distribution of where they're located and total numbers of people. the cost of providing services is increasing. Each piece of equipment, they used to come at $50,000, then $100,000. Now they start at $1 million, plus you spend $1 million on the room you put them in. The fact is, equipment is more and more expensive for us, and that drives cost up. And finally, competition and transparency is becoming the new norm. At the debate I was at, the head of Geisinger, which is a huge health care delivery system in Pennsylvania, was there, and they've gone to flat pricing. Not on everything, but lots of things. You know, X for the colonoscopy, X for the knee replacement, so much to have the baby, flat fee. If it costs more, that's their problem. If it costs less, that's their benefit. We're going to see more and more of that, and we're going to see it available publicly so people can shop. And we all know that shopping, very much like people that go to kayak to shop for airfares, they are going to go to hospitals and shop for healthcare costs, and it's going to drive prices down. And in fact, it's coming up on our patient portal, but we're very close. You'll be able to put in the procedure you're looking for, the insurance you have, and we'll tell you what the average person pays for that. And multiple hospital and delivery systems like us are going to have the same thing, and that's going to drive our pricing down. So what do we need to do? There's no question. Spread your overheads over a wider base. I mean, the truth is, billing $100 million or billing $110 million doesn't really cost a lot different. And so the bigger base of business, you can drive your overhead costs, and that's billing and back office and IT and certain types of facilities and equipment utilization and all those kinds of things. And so there's a huge push on for people to work across the broader base of business. Some people talk about regionalization or expansion in various kinds of ways. And you're seeing that. The big mass providers around Boston have all crept up along the New Hampshire border. The New Hampshire guys are creeping down along the Mass border. People are expanding the nature and scope of that. We just don't have any more people. I mean, we have what we have here. And so for us, expansion means geographic expansion. And we are exploring ways to affiliate, amalgamate, partner, venture, somehow work with those people that we compete with today in order to rationalize our services. The truth of the matter is we don't need an MRI every 25 miles. We don't need a 64-cut CAT scan every 25 miles. We don't need a lot of things that we have. So if we have one that's 50% utilized and the next person has one that's 50% utilized, we would do a whole lot better if we had one that was 100% utilized. Of course, the devil of that is who's won, and those are all things that we're trying to rationalize and work through with other parties in the North Country. And finally, as you think about all those things, you say to yourself, well, how do we continue to preserve our service to the community? And the truth is, we can't be all things to all people all the time. There are limits to what we can do in the size and scope of our activities, and we're trying to decide where those limits are and how we reach those. Let me just say, people say all the time, we have great staff, right? I ran a business, and we have a great staff. We really do have a great staff. You can tell I'm not in Franconia all winter. I've been in South Franconia. I'm in Florida, and we have a hospital there in the community that I'm in. It's a small to mid-sized community. Last month, the average wait time in the emergency room from the time you arrived at emergency until you were admitted to the hospital, if you needed to be admitted, was 6 hours. The average wait time in the emergency room was over an hour. That is an emergency unto itself. And the reality is the level of service that people receive here, the quality of the care that they get, the caringness of the people, I hear it all the time, really is exceptional. And more importantly, I think our staff understands what's happening and how things are changing and is cooperative in that process as opposed to resistant, which is really part of the challenge of changing the way healthcare is being delivered. As Bill's pointed out and everybody's mentioned, we really are in a salt. We've been able to make money every year, not as much as we'd like, but enough. We are not heavily indebted. We have almost as much cash as we have debt. So we have a lot of flexibility to build and do the things we need to do. We have modern facilities. I happen to be here the day that some people from Dartmouth were here who are interested in pain management, and they were blown away by the quality of the facilities, the new infusion facilities, the access to a whole bunch of things we have here that other people just simply don't have. And so what we like to say, we think we know what we need to do, but the details are a work in progress. We think it's a good time for us. We think we'll do well in that, but there certainly are challenges we're going to continue to face. Warren?
So thank you, Steve, and thank you all of you for coming out to our 107th community meeting. That's a great number. We're very proud of that. So what I want to do is spend a little bit of time. Steve set the stage about the environment that we're in, but the other challenge we have with the environment we're in is dealing with healthcare reform under the Affordable Care Act and all of the changes that are associated with that. And as we see it, and as I study the Affordable Care Act is intentionally designed to radically alter the system of healthcare that is in this nation. And so the four goals of the Affordable Care Act are access, right? 32 million Americans are going to get some kind of healthcare coverage. Cost, Steve talked about it. They want to drop or lower the cost curve and cut the cost curve and reduce the expenditure per capita in the nation. Affordability, they want to expand Medicaid. This state, however, is not doing that at this point, one of 24 in the country, one of 25 in the country. And they want to provide insurance subsidies under the exchange, which is happening here in this state, and we are part of that exchange. And finally, and probably most radical, is the concept of quality, clinical best practices, aligning rewards for quality, and changing from what Steve talked about, fee-for-service and volume-based reimbursement, to this value-based reimbursement methodology that we need to be prepared to overcome. So if you think about where we are today, we've got the old growth model of fee-for-service, and we're sitting right here in the middle of trying to transition from an old growth model to a new growth model. And quite frankly, as Steve has indicated, we can only read so many of the tea leaves. So we've got to start changing the course of this organization based on what we're going to anticipate is going to happen through the Accountable Care Organization, through the Affordable Care Act. What are the implications for healthcare reform? Steve hit a lot of these. Downward pressure on reimbursement. And that is going to dramatically affect who we are and how we operate. We're going to move from this value-based concept to volume-based to value-based. The federal government has deemed this as value-based purchasing. As Bill pointed out, 40% of our revenue comes from the federal government. They want to hold all of the providers, the hospitals and their physicians accountable for outcome, for patient satisfaction, and for quality. Because of the first two items, we've got to rebalance our cost structure is what they're saying. People are saying anywhere from 15 to 20% of your cost structure needs to go away if you're going to survive in this new universe. We need to figure out a plan to overcome that. Clearly, we've got challenges with primary care, recruiting. There's not enough primary care docs out there. We need to figure out how to meet that need in this community. Increased consumer responsibility, and that's why we're putting the estimator on our website. We need to be much more transparent with our pricing structure, because folks like us now are on high deductible plans. First dollar out of pocket is ours. We're going to start shopping around. The only way we can win that is have competitive pricing. The only way we can do that is get our cost structure down. Joint accountability for care and reimbursement via population health management. This is another radical feature of the Affordable Care Act. And basically it's saying, the federal government is saying to us, providers, you, Mr. Hospital, and you, physicians and mid-levels, and the insurance company are responsible for population health. Who's left out of the equation there? The individual patient. But we are still responsible for improving the health care of a region of population. And lastly, because of all these implications, what we're seeing in the market right now is major market consolidation. I don't think in the last 3 weeks that the headlines haven't started with another hospital has joined Dartmouth Hitchcock. Whether it's New London, Alice Pacte, which just announced, Mount Ascutney in Vermont. Shortly, Cheshire Medical Center will be announcing that. So more and more affiliations, mergers, and consolidations are going to be happening. What do we mean by this next curve, this second curve? So right now we're sort of paid, our primary focus is on sick care. Tomorrow or in the future we got to focus on wellness and prevention, right? Care management, we manage it within our own setting. In the future we've got to spend time on ongoing health and episodes of care, working with other partners. Right now, our delivery models is fragmented and siloed. We have our four walls. FQHC downtown Amanuense has their four walls. Home health does as well. We've got to learn to work together in a continuum of care and a coordination. Right care, right place, right time. So the walls have got to come down. In the care setting, so what do we do now? We see patients in the office, in the hospital. In the future, we're going to see them at home. We're going to deal with them through e-health. We're going to deal with them through mHealth, mobile health. So there's going to be different vehicles, and how we make this transition is going to be critical. Our physician platforms, right? A bunch of solo practitioners. We have a group of physicians here at this institution. I wouldn't tell you today we have a group of practicing physicians. They're all sort of functioning independent. We need to tie them together better, a multi-specialty integrated group. We need to work on our clinical support systems, right? It's transactional now. It needs to be interoperable. We need to have a healthcare exchange among all of our partners in the region. Focused quality measures, they've got to be on outcome and population-based, because that's how we're going to be reimbursed. Reimbursement, fee-for-service today. Tomorrow it is changing based on outcome, utilization, and total cost. That is a different world for us. Financial incentives. Today, as Steve said, we do more, we get paid more, right? Fee-for-service. That is going to be going away or fading out, and eventually it's going to be value-based. And then finally, right now we do more, perform better, we make more, right? That's what we have to do, is perform better. And finally, how do we make money now? It's on a margin per service. Soon it's going to be a margin per life, especially when we get to capitation. So I want to talk a little further about that. So this is a busy chart, but here's where we are now, fee-for-service. Steve mentioned that a lot of hospitals are experimenting, tertiary care facilities, large hospitals are experimenting with the shared savings. Many hospitals have succeeded, many have not. What is that? Well, the federal government are saying to Dartmouth-Hitchcock, you care for 50,000 lives. Last year it cost $1 million to take care of those 50,000 lives. If next year you're able to do it for 900,000, we'll split the difference with you and give you some shared savings back. So that's a model that we're going to be moving towards. Episode bundled payments, another model that we need to move towards. And the best example I can give you is Dr. Sauter. When he delivers a baby, he gets a bundled payment for all of the care that patient needs from the time they come to his office initially and say, yes, you're pregnant, to the time you go home with your baby. He gets one fixed fee for that. So more and more bundled payments are coming our way, whether it's for knee replacements, shoulder replacements, but they're going to group it. From the time you get to see the physician to the time you get discharged out of your rehab and back to the slopes, if that's what your goal is, we're going to get one fee for that, and it's going to be lower than what we get now. Global payments is another scheme they're working on, which will say, okay, Littleton Regional, you have 5,000 Medicaid lives right now. We're going to pay you X amount to take care of those lives for a year, which is really tricky if you don't have the systems to know what you're doing for those patients. And lastly, traditional capitation is going to come back, a per member per month fee that we will receive. The challenge that we face in this radical change in how we do things is the risk burden is going to be on us, the providers, to make sure we're able to succeed in these new models. But right now, we don't have the infrastructure, the expertise, the understanding of how we can do actuarials, how we can do claims management, how we can do big data to be able to understand how we can manage in this brave new world. And that's the challenge that we have to overcome. So what's coming? We've talked about lower payments. We've talked about this financial risk. Talked about the inability to shift cost. A number of hospitals, not us yet, are getting downgraded because the revenue stream's not there and they haven't gotten the costs down. And really, what is going to happen down the road is we've got to focus on size, scale, and systemness. We've got to develop a system in the North Country of healthcare different than what we have today. Success will require efficient operations. We've been working on that for years. Strong physician alignment. You saw the numbers. You saw what we're doing with our physicians. Effective clinical transformation, where and how and when care is provided. And finally, most importantly, we need to learn how to manage beyond our four walls of the hospital, which is what we do today. But tomorrow, it will be a different world, and we've got to figure out how to do that. So, what are we doing? Our biggest challenge is to make sure we fulfill our mission. That's the goal of the board and administration, to make sure we fulfill the mission of Littleton Regional Healthcare. We've got to learn how to manage health of a regional population. And what population do we have? Upper Grafton and Coos County. What population in the state is the least healthiest? Oh, I'm sorry. Upper Grafton and Coos County. So that will be a real challenge, but we have to learn how to get people healthier. Keep them out of the hospital, keep them out of the ED, keep them out of our physician offices. That's the game in the future. So we got to build scale in the North Country in a unified system. We got to make sure we have a sustainable healthcare system in the North Country to service our patient population. Our patient population isn't growing, but we've got to figure out how we work together to get them all healthier. And finally, we got to do some regional planning to address changes in the environment. The solution we're working on is that we cannot do this alone. We cannot sit in our four walls and master the brave new world that's coming our way. We must partner with our friends in the North Country, the hospitals, the FQHCs, the home health agencies, the nursing homes, the private physicians. We must reinvent healthcare in the North Country as we know it today. I don't think any of us would recreate the system we have in the North Country as a health system. We'd say it's not working. We'd say we have 4 hospitals that are competing with a stagnant population. We'd say we have 3 FQHCs that are sort of competing and collaborating, if you will, with the hospitals. We've got nursing homes. We've got private practitioners. We need to redefine how we do our work. And finally, because of the challenges with risk and taking on risk with the new payment mechanisms, we've got to partner down the road with the tertiary care facility who has practiced in ACO, Accountable Care Organization pilot programs and have succeeded because they'll have the big data, they'll have the information we need, they'll have the experience. So the board has authorized me to work first with the 3 hospitals in the North Country to figure out if we can come up with a new organizational structure where we can systemize healthcare in the North Country, where we can rationalize healthcare in the North Country. After we get successful in that, we need to expand the tent with the FQHCs, home health care, and the nursing homes, so we're all in this game together, taking on risk together and taking on a continuum of care throughout the North Country, and join some kind of tertiary care facility that would be a potential Dartmouth or some other large teaching institution that is practiced and good at what they do with regard to ACOs, Accountable Care Organizations. In summary, change is required. Healthcare continues to evolve. I've been in this business for 30 years. Change has been a constant for all 30 years. But what I will tell you is change will be much more rapid in the next 3 to 5 years. Bigger is better. Size and scale will matter in the future, and that's why we need to work with our friends in the North Country. We have a chance to reinvent healthcare in the North Country, make it right for everybody. Change won't be easy. There'll be some very difficult decisions we need to make as we try to survive in this brave new world. But I think the good news is, as we reinvent healthcare, we can focus on our patients and their health and improve the population health of everybody in the North Country, which will be our goal as we move forward. So bear with us. Help us and be patient with us as we try to reinvent healthcare in the North Country, as we try to read the tea leaves that aren't quite defined yet from Washington, as we try to continue to meet our mission and meet all of your healthcare needs. We have been on the right track, as Bill and Steve have both said. We just need to continue to move down that track so we don't get run over, and we won't. So I want to thank you tonight. I want to say it is an absolute privilege every day to come to work and support and serve all of the family at LRH. And it is an honor to be here as a healthcare provider and take care of the lives who entrust us with their care. Have a great night, and thank you for coming out.